So this is really focusing, as we've heard, on variceal bleeding, and particularly the acute situation, and the role of preemptive, or as some people would like to call in the UK, we quite like to use the word early tips rather than preemptive. These are my disclosures. So variceal bleeding remains a significant complication of a liver disease. It is a mark of decompensation, and the mortality associated with variceal bleeding is still pretty high, 15% at 4 weeks, according to a recent audit in the UK, but most literature would say it was around 20% at 6 weeks. And TIPS has been with us since the late 1980s, and it has revolutionized the treatment of portal hypertension and variceal bleeding. However, there is some recent emerging data which adds to the debate about the role of TIPS, particularly in the acute variceal bleeding situation. So my talk is really focusing around the case. I thought it'd be quite nice to, because, you know, as you mentioned earlier on, you might get a call about a particular case. So I'm actually going to just discuss a case where we actually had that call. Are you or are you not going to offer a TIPS? So this is a young male patient who has a history of alcohol-related liver disease. And this is a real case. So he had a previous admission 4 weeks prior to this current presentation to the emergency department with seizures. There's a strong history of alcohol. Previous presentation was complicated by variceal bleeding. Sadly, as often the case in patients who continue to drink a lot, compliance was far from ideal. He didn't take his tablets and he didn't attend any endoscopic sessions for secondary prevention of variceal bleeding. And when he was admitted, he continued to consume 16 units of alcohol per day, and he was hypotensive, tachycardic, pretty hyperdynamic. We wondered about infection, and the polymorph count of 239 is borderline, but we assumed that he had probably got peritonitis and treated him as such with antibiotics and albumin. The liver numbers, as you can see, not great. Bilirubin of 89 micromoles or 5.2 milligrams per deciliter, a low albumin, high INR. So this is a sick young man who continues to drink a lot and has presented probably with sepsis, with hypertension. So this is the first of two questions. This is a poll. So I think if you could maybe have the poll. So the steps would really, what would you do next? Continue the propranolol, discontinue propranolol, continue at lower dose, change to carvedilol and titrate, continue propranolol and add in a nitrate, with titration according to HVPG, or suspend propranolol and consider restarting it when the patient is stable. So those are the 5 options. If we could maybe start the voting. Do we have the voting screen? Don't know if I can see the voting. Oh, something's come. Yeah, so that's great. So I'd be grateful if you could start the voting. We'll maybe give about 30 seconds for this. See if. Okay. Right. So there is a clear preference here for option 5. Some would discontinue propranolol indefinitely. Some would go for option 3, which is to switch to carvedilol, which is one of my favorite drugs. And then option 4 is nitrate. So what I'm going to do is just going to share my screen and go back to my presentation again. So I think most of us would probably suspend propranolol. The patient was hypotensive, and it's probably not a good idea, and possibly in the context of sepsis. And this is the guidelines from EASL and also ASLD. So when a patient is hypotensive on a beta blocker, should really be discontinued. Consider reinstatement after recovery. And if the patient is intolerant to beta blockers, then TIPS is an option. Beta blockers are the mainstay of treatment, cornerstone of combination therapy. And if a patient can't tolerate a beta blocker, TIPS should be considered. So we suspended the propranolol, and about 12 hours later, he had a bleed. Whether it was related to stopping the propranolol, as I've said, he hadn't really been drinking any. He hadn't been taking his medicines. So he went on to probably have a GI bleed with hemodynamic compromise. also developed encephalopathy, HB down to 57, and we resuscitate him with normal standard of care with vasoactive drugs and antibiotics. And this is his bloods, hemoglobin down to 58. And then INR remains steady. And importantly, the renal function has remained stable throughout all of this. So he went on to have an endoscopy, big varices, banded, GOV2 gastric varices, and we managed to get hemostasis with 5 bands. And he was transferred to the ICU or ITU and remained reasonably stable. Ultrasound scan showed features of cirrhosis, patent portal vein and ascites. The repeat acidic tap showed that there was a reduction in the white cells. CT brain, slightly small brain as you'd expect in this kind of patient, drinks a lot. CT abdomen showed a patent portal vein and a cirrhotic liver with ascites. So this is a case of a patient, a young patient who has a variceal rebleed, but hasn't really had proper secondary prophylaxis. Child-Pugh C of 12, MELD of 21. So this is our second and last of the voting. So if we could maybe go to the voting screen again. So the options are band. What would you do next? So this is somebody who's reasonably stable after hemostasis following banding of esophageal varices. Would you band and propranolol, carvedilol, and banding and propranolol, banding and carvedilol tips, the secondary prophylaxis tips, preemptive, or tips only if HVPG is above 20? So if we could maybe have the voting. Okay. Okay, so we'll give this about 30 seconds or so. Start the poll. Okay. Ooh, interesting. There's a real spread here, isn't there? So most actually would go for banding and propranolol, and actually only a minority would consider the tips of secondary prophylaxis, and slightly more would consider preemptive tips. Similar number considering tips if the HVPG is above 20. Okay, so I'm going to go back to my talk. This is really interesting. So I'm going to just share my screen again. Going back to my talk. So this is interesting. So we'll move on to the next slide. Preemptive tips. So we really need to understand this concept, because, as I said, this is your call. What are you going to do? Are you going to offer a tips, or are you going to continue with banding, propranolol, given that the patient has probably failed on those, not taken them? So I'm just going to introduce, I'm going to look at the literature, but I think probably just as important, if not more, is to understand what is an early or preemptive tips. So this is the study design of all the trials, really. So these are patients who are high risk, defined by a Child-Pugh score and also by active bleeding. And the maximum threshold is Child-Pugh score of above 13 would really be too high risk to undergo such a major intervention. And there's controlled acute variceal bleeding. Patients are treated with vasoactive drugs, antibiotics, and then at that point, when they have the endoscopy, at the time of diagnostic endoscopy, patients are then randomized to either the early preemptive tips within 72 hours of the diagnostic endoscopy. This is when the clock is ticking, ideally within 24 hours. And then the other arm is to continue with the standard of care with secondary prophylaxis, which actually most have gone for this option. So this is very important concept to understand. So what is this preemptive tips? It's not a tips, a salvage tips. As I've said, these patients reasonably controlled in terms of hemostasis. So it's a patient admitted with a bleed, has the endoscopy, successful hemostasis, and then randomization at the time of the diagnostic endoscopy to early tips within 3 days of the diagnostic endoscopy. So that's the early tips arm. Standard of care arm, The Bovino criteria is that the bleeding episode is 120 hours or 5 days from the time of index bleed. So you have this 5-day window of an acute bleed, and the randomization again, like for the early tips arm, is at the time of diagnostic endoscopy. And then after this 5-day acute bleed, then the patients are offered secondary prophylaxis, which actually most of the audience have opted for. So this early or preemptive TIPS is really an option in a patient who's actually either failed secondary prophylaxis or who meets the criteria in terms of severity of liver disease and high-risk criteria, but before failure. So if a patient has failed initial therapy and requires a sense-stacking tube prior to the decision being made for early TIPS, and that isn't early TIPS. So I'm just going to run through the studies. I'm sure you'll be aware of most of these. So this was the landmark study published in the New England Journal by Garcia Pagan et al. So this is patients who have child C or child B inactive bleeding. Clear difference in favor of early TIPS. Note the composite, it's a composite endpoint of bleeding, uncontrolled freedom of uncontrolled bleeding or rebleeding. That was the primary outcome. And the survival was a secondary outcome, but again, TIPS comes out really good in both these outcome measures. There was no difference in hepatic encephalopathy. Number needed to treat to prevent death was only four. So this led to a lot of change in practice. Then there was a bit of a gap, I have to say. There were no other randomized trials. There were some observational studies, and the only next randomized trial was about 9 years later from China. Exactly similar kind of cohort. However, patients, regardless of active bleeding, were included. The patients had Child's B or C cirrhosis. Primary outcome, this is important. The primary outcome was 1 year transplant-free survival. Remember, in the Garcia Pagan study, it was a composite outcome. And the outcomes are interesting. Again, in favor of TIPS, but look at these confidence intervals, 0.25 to 0.98, just about significant, 0.04. The standard of care has improved considerably compared to 9 years ago. So the difference is not that great. So precision is not very good, I have to say, because the sample size is probably small. It was a 2-to-1 randomization. There was no difference in encephalopathy. And most of the patients had hep B cirrhosis, which may not apply to some areas of the world where most of the liver disease is due to alcohol. And the other study, the most recent one published, well, it was presented at the BSG, but now it's actually published in Alimentary Pharmacology and Therapeutics, is the study from the UK. Patients with Child's B or C cirrhosis, regardless of active bleeding, were randomized to early TIPS. About just around 50% received within the 72 hours, and most of the rest received it within a 5-day period. So there were some protocol deviations. So 10 to 29 in each arm. These trials are notoriously difficult to recruit into because of so many exclusions. The results were surprising. Absolutely no difference in the outcomes in terms of survival. There was a trend towards reduced bleeding. The severity of liver disease was very similar to the Garcia Pagan study, although obviously active bleeding wasn't an necessarily inclusion criteria. And when there was a per protocol analysis, there was less rebleeding. Encephalopathy exactly the same. So really interesting. And to be shown in the British Liver Association meeting, a meta-analysis of these 3 trials actually showed there was no difference in 1 year survival. So really we need a large randomized trial, adequately powered. That's our opinion anyway, before we can make a call on early TIPS, because the evidence is now a little bit less clear. I'm just going to run through these next 2 or 3 slides. These are observational studies, obviously not quite as high impact as the RCT. French studies showing how difficult it is to get an early TIPS. Very few patients who were eligible actually underwent an early TIPS, and the benefit was only seen in those with child C disease. And in this study from multicenter Spain, I think North America, Canada, a large observational study showing overall benefit of early TIPS, particularly seen in child C, but not in child B inactive bleeding. There was a subsequent Chinese study published in Gut showing actually a huge study, 1,000+ patients in standard of care arm, showing a benefit in child B inactive bleeding, which goes against the Hernandez-Guia paper. And a more recent study showing that TIPS can be effective in ACLF, mostly grades 1 to 2. Small, very small size, a bit of a fudge in terms of statistics. Propensity score matching was done. So I think really this needs further validation. It's a bit of a dilemma for clinicians. What are we going to do? There's a survival benefit in some studies, but not in other studies. And median sample size is 60. The studies we think lack precision. And in fact, our meta-analysis shows that the overall quality was pretty low in these studies. So the guidelines, our guidelines was published in GUT this year from the UK, recommend further studies to look at the child's B, male 12 to 18. Probably I'm only seeing the benefit in child C, but more study needed in the other groups. Mirrors the EASL guidelines. And really, it's an interesting topic. So very logistically, very difficult to perform in early tips because of this clock ticking and the time factor. And whether all patients benefit from early tips is really open to debate, I have to say. So back to this case, what did we do? So we decided actually that he was ineligible for early tips because this is day 3. He'd failed secondary prophylaxis. He's a child C. So actually would be considered even for the Garcia-Pagan study because he hadn't had adequate secondary prophylaxis, and that is an inclusion criteria. So he went on to have a TIPS with a good reduction in the portal pressure gradient, did reasonably well, standard covered Vietro stent, no complications during the procedure, but developed encephalopathy and a bit of a pneumonia, but got better and lived to tell the tale. Discharged on rifaximin and diuretics, liver numbers reasonably steady. Importantly, renal function remains stable throughout. So up till January last year, he was doing well and abstinent from alcohol. Encephalopathy was improving. So he's done reasonably well. So that's my talk and case. And it's interesting because, again, I'm going back to we need to understand what early tips is. And I think that there's a lot of, even I was a bit, I have to say I've had lots of discussions with my colleagues about what is this early tips? It's not salvage tips, it's not secondary prophylaxis, it's early tips within this defined time window, but before there is treatment failure. I think that's the main thing to reinforce. Thank you very much for your attention.
Okay, thanks, Dhiraj. That's as you pretty comprehensively covered. As you said, there's probably 3 randomized trials, and of course your own meta-analysis done on this. There is a question from Shamsher. I think what he's asking is, can we go ahead with tips if there's a history of overt encephalopathy in the last 3 months prior to the presentation? What's your opinion on that?
Okay. So this is an excellent question. So we always worry about encephalopathy, don't we? We all have seen it, and encephalopathy is a devastating complication of TIPS, and we want to do the best for our patients to minimize this risk. So if a patient is admitted with acute encephalopathy in the context of a bleed, that's very different from a patient who's had recurrent admissions with encephalopathy in the last few months. And in fact, at the ILC, the International Liver Congress, well, it's that digital congress, everything is digital these days, isn't it? So there was an interesting paper showing that doing the TIPS in an acute situation with acute encephalopathy actually was not detrimental to the patient. So in the acute situation, I don't have so much concern about acute encephalopathy as in this case. However, if a patient has had recurrent episodes of encephalopathy, requiring, I think it should be requiring admissions, then I wouldn't, it's actually, it would be an exclusion criteria for quite a number of studies. So I'll probably say no if there was recurrent hepatic encephalopathy.
Yeah, couple more questions we'll take. One from Dr. Sandeep Satsangi. I think what he essentially is asking is, even within child C, would you use MEL score to differentiate between people who would be higher risk for TIPS? So where does MEL score fit in amongst all of this?
So as I said in my, I think a Chinese study, the LV study, highlighted that the male 12 to 18 benefited. There was quite a benefit in that group. MELD above 19 was okay. I think with child C, I wouldn't really consider at this stage on anybody with a child C over 13. I don't really know about the threat because we use mainly child Pew scoring to make decisions. But in terms of MELD scoring, the MELD 12 to 18, but MELD, in fact, even higher MELDs can still benefit. But I don't actually have enough data to say what's the absolute upper limit for MELD.
Okay, and I think there's one last question, which is technical. What kind of HVPG reduction would you be happy to go home after your TIPS done?
Yes. So that the most of the data I would point to, and again in our TIPS guideline in the UK guideline is a reduction to less than 12 millimeters of mercury, or a 20% reduction would be acceptable for second. This is mainly data from secondary prophylaxis, but the usual recommendation is for, and certainly our radiologists normally aim for, in the context of bleeding, would aim for a less than 12 millimeters of mercury. But having said that, we published a paper many years ago from Edinburgh showing that in gastric variceal bleeding, you're probably maybe aiming for even lower pressure. And we'd actually recommended, this wasn't a randomized trial, but a large retrospective study, that a pressure of less than 8 millimeters of mercury is probably a better option. But you have to balance that against the risk of hepatic encephalopathy. So it's a bit of a balance. But for most, I think, indications it would be less than 12 millimeters of mercury, total pressure gradient after TIPS.
And probably the last question. HVPG, how often do you do that in your practice, especially in the context of variceal bleeding?
So yeah, so if we look at the situation throughout the European Union, there are a number of centres, and the centre where I trained in Edinburgh, we used to do a lot, mainly in the context of research. However, if we, outside of the context of research, very little in terms of deciding on therapies, on stratifying risk. It isn't available in most of the hospitals. It's only in the larger hospitals, and even if it is available, the expertise, again, it's technique, and it requires. Some would say it's easy, but you have to be careful about the technique, and you need to be doing a reasonable number, like with any of these procedures, to be to be confident in it. So I don't think we don't really do it routinely in clinical practice, and only really the one time when it's done probably more frequently are in centres who do a lot of transjugular liver biopsies. Often HVPG is done at the same time as a TJ biopsy. Some of the sites in London do a lot. We used to do lots of them, but maybe not so many biopsies these days because of other non-invasive markers.
Okay, thanks, Dhiraj. Anybody else has any question from the panel? Yes, Mana.
Dr. Dhiraj, so while we're talking about HVPG, do you think adding HVPG as a variable to decide who gets early tips might redefine and give you a better advantage in a subgroup of patients? So your decision of early tips, if you base it on HVPG, what is your thought on that?
Yes, so if we look back at that study by Moniscello, I mean, I didn't go into the detail in that study. This was I think this is the study in early 2000s, wasn't it? And they, this is, remember, bare stents, standard of care, not the same as what we're doing now. They didn't, I think the endoscopic treatment was not predominantly banding, and vasoactive drugs maybe were not used so much. So the standard of care was not the same. Now, to offer HVPG, this is within 24 hours of a bleed, of coming in. Can you imagine the logistics of doing that? It's hard enough to get an OGD done without, and trying to get all the anaesthetist, and then you've got to get an IR guy who can do an HVPG well. Within 24 hours, this patient's kind of, I think Gesep again, when I spoke to him, he said, yeah, even in Barcelona, we'd struggle with that one, to do it in clinical practice. So it's kind of not really feasible in this acute situation. But I see where you're coming from. It may help to stratify.
Okay, Manav. Do you want to follow up on that, and then we'll close?
You can do just one last thing. Sorry. So if you can do tips in 72 hours, you can do HVPG before that. That's what I'm asking. So my question is very straight. to define who gets early tips? Would you like to base your decision on HVPG before you go ahead and do tips?
I don't think it's necessary. I think clinical parameters are just as good, and there are some studies which show it. They can be just as good as particularly with regards transfer. Because if you remember, a tip center, you're getting referrals from elsewhere, smaller hospitals. They won't be able to do the HVPG, whereas they can give you the Child-Pugh score or the MELD score to make a decision. So that's the real world.
Okay, fine. Okay, great. Thanks, Dr. Dhiraj, and thank you everyone for all the questions. That's great to have that.